Thank you everyone for joining us. This is our SOAP Notes workshop, part of our telehealth case competition. We're excited to have everyone here. As a reminder, this workshop is being recorded. If you have any questions, you can always send them in the chat box. Myself, Olivia, and Jerome are on the call as well. And we'll be sure that we communicate the recording from today's workshop. And I'm going to turn it over to our guest speaker today, one of our collaborators for the case competition, a huge supporter of NSU, Sergeant Allen. I'll let him introduce himself and jump into the topic today. But again, thank you everyone for joining us. And Sergeant Allen, thank you for providing this opportunity for our students.
No, absolutely. Thank you for having me. Can everybody hear me okay? Thumbs up, somebody?
Yes, I can hear
Yeah.
you.
Perfect. So as you said, I'm Sergeant First Class Anthony Allen. You can call me Sergeant Allen. You can call me Anthony. You can call me just Sergeant if that's easier. Whatever you're most comfortable with is fine. Mr. Allen makes me sound a little old, so I prefer not that one, but that's okay. As Amelia said, we're going to go over SOAP notes, and I'll explain what that is here in a little bit. I just want to let you kind of know a little bit about myself so you don't feel like you're talking to a stranger. I am a sergeant first class in the Army, which is an E7, a little bit higher in the enlisted side rank. I've been a combat medic for the last 13 years on the active duty side, and I did a few years in the reserves. So altogether, it's about 15 years service. I have been to just all over the dang country, from Texas to Washington to Hawaii to Arizona, and now to lovely South Florida. So I have a lot of different experiences and a lot of different climates. I've been deployed twice, once to Iraq, once to Afghanistan, both of those times as a combat medic in that role. So I have a lot of experience with the trauma side of things, and then as well as just kind of how the deployed environment is. If you have any questions on that, I'm more than happy to ask those or answer those questions. The most important thing is that I've been married and have two very energetic young boys, and they keep me busy and they sap most of my energy. So I'm gonna do my best to bring it today. With that, we will get into the class. I will share my screen. Let me figure this out. It's all technical and stuff. There we go. Okay. Oh, it's on the wrong page. My bad. All right. So SOAP notes, again, that's me, Sergeant First Class Anthony Allen. What a SOAP note is, or what its purpose is, we'll go into that next, is documentation, organization, to improve communication and quality control. Those are the key things. Documentation being probably one of the most important ones because it has a lot of impact on just the patient care in general. So we'll get into that first. So with documentation, the things that you're going to be putting in those records is the patient's history, which is going to help to guide that patient care over time. There's a lot of different things that can be included in that, whether it's prescription or just in general medication history, injuries, and then illnesses is obviously a big one, because if something starts out as maybe like an acute illness and then it could eventually become a chronic thing. Another huge thing with documentation is identifying those health concerns. So when you're reviewing a patient's history through their previous documentation, you should be able to identify things from their history that could be impacting their current complaint or issue. And so that, with that accuracy, can save lives, obviously, because you might find something like, hey, this is like a huge red flag that was missed previously, but somebody was good enough to make sure they documented it, and then you found it, and as it relates with your current issue, it could potentially be something that could end up saving somebody's life. Monitoring the response, and that's going to be just the effectiveness of that treatment. So is the treatment that you're doing going to be effective? So if it is an illness, sometimes those illnesses or injuries or whatever will take a long time for them to heal or for you to overcome those things. And so you want to make sure that whatever your treatment plan is effective. Speaking of illnesses specifically, and with our current situation, which is a virus, if you started treating somebody that was sick today with, say, antibacterial or antibiotics, and they actually have, say, corona or something similar, and it's a viral thing, you could potentially make it worse. And if you're monitoring the response with accurate documentation, you could catch it, change your treatment plan, and then treat the actual issue. And vice versa, if it's bacterial and you're treating it as it was a virus, you can make sure that you change up what you're doing to get a more effective treatment plan. And then obviously just maintaining that record so that you have a good picture, the good holistic picture of what that person's health conditions have been and currently are. Um, and with at least with the military, if it didn't, or if it wasn't documented, it didn't happen. And that's important for us specifically just because with the patient history, if we don't have it in documentation when they go to get out of the military and they want to get disability or VA benefits, they have to have it documented, or else it's just like it never happened, and that just becomes a paperwork nightmare. So that is the main reason why documentation is so important. Just the health history, obviously, as well as making sure that that patient's taken care of for the long run. So now we're going to talk about the actual SOAP note itself, and what that is the SOAP note is just a tool of documentation that we use in the military, and SOAP is actually an acronym which stands for subjective, objective, assessment, and plan. And it's just kind of our step-by-step guide on how to get through that patient encounter and make sure that we're documenting everything that we need to document. Um, Sorry, I'm using two screens, so I'm making sure I catch everything. So first, we're going to talk about the subjective section. That's where you want to start. That's going to be what the patient tells you, right? And just kind of like their demographic information as well. So their age, their sex, their ethnic background, their chief complaint, the history of their present illness. So all these things that you got to ask questions about so that you can get the information you need to form an accurate picture of what's going on. So like I said, the big ones, demographic information. And if you know the shorthand when you're writing these out, that's great. It makes it a little bit faster. But I've always learned that shorthand it's a good tool, but it's not a necessity. So if you don't know the shorthand, that's fine. Make sure you write it out so you get an accurate picture of what's going on. Accuracy is more important than speed in this particular situation. The next thing you want to do after the demographics is the chief complaint. You want to make sure whatever they're in the office for that day or whatever, it's a virtual, so whatever they're seeing or talking to you about that day is documented clearly in the subjective section so that when the provider or so when you go to look at it, you can find exactly what it is you're trying to figure out to treat. History of present illness, how long has it been going on? What are the current symptoms? Those sort of questions, those fact-finding questions, if you will, so that you can get to the root cause of what's happening. And you know how long it's been going on, how severe it might be. So if you've been sick for 3 weeks, it's a lot bigger deal than if, oh, I've had the sniffles for a day. You know, that's two different things. So you want to make sure that you're capturing what that is. Past medical history is a huge one for the subjective portion. And again, you don't want to just ask, hey, do you have any past medical history that pertains to this issue? Those yes, no questions tend to lead to very simplified answers for something that could be more complex. So it's tell me about your past history, your health history. Like, does your family have any concerns or history of illnesses? And if so, what are they? Those open ended questions can get you more information. Past surgical history, that one's pretty cut and dry. Have you ever had surgery? And if so, what was it? So you know if potentially that surgery is affecting, what's going on today. And then some of the other things are more environmental factors, like your family history, the social history of just you in general. So certain people from certain regions of the world might be more susceptible to a certain kind of infection or whatever. Your family history is their history of heart disease, diabetes, any like chronic illnesses that are genetic and you might be transmitted to you. And then obviously the ones that you want to ask everybody is going to be the medications and allergies. Those are going to be huge just because if they're on any current medications and you need to prescribe them something else, is the medication that you want to prescribe going to interact with the medication they're currently taking? And if so, you need to figure out a different medication to prescribe to that patient. And then allergies, you don't want to obviously prescribe a medication that they're allergic to or a treatment plan that they're allergic to. So if someone's allergic to penicillin, you don't want to prescribe them penicillin, right? Pretty self-explanatory. And then review of symptoms. So that's where you're kind of going to go through from the head to toe. You're just going to review all like the bodily symptoms that are pertaining to the chief complaint. So we call it HENT, so head, eyes, ears, nose, throat. Those are the big ones that have to do with most of our upper respiratory infections and diseases. So going through those is huge. You're gonna, look at all that stuff and kind of just see what's going on, or ask them if they have any concerns with those specific symptoms or systems. Sorry. So the next one is objective. This one's going to be a little bit tougher to do from a virtual position because what it is what you see. So the signs and symptoms that you personally can observe. And like I said, it's tough to do virtually. So subjective is definitely going to be your bread and butter for the virtual environment. But for fun, we'll talk about the objective side if you weren't virtual and see if you can come up with any creative solutions to apply it to the virtual setting. So that's where you're going to be checking a lot of different things, your vital signs. That's when you're going to, if you were, co-located with that patient in person, you could put your hands on them if it's like a musculoskeletal issue and do a full knee exam or shoulder exam or ankle exam and be looking at all those things so you can determine, is it a sprain, is it a tear, like what's actually going on, as much as you can, obviously without like x-rays or MRIs or any of that stuff. So you want to check the gait, the posture, the movement. So these things you can do virtually if you can get the patient up and moving to kind of just see how they're moving. Does it look abnormal? Does them doing a squat or a lunge or something look like it's causing them physical pain? If they're straightening their leg, are they grimacing? Like things that you can see the patient from or see from the patient. That's the big thing with the objective category, is so that you can find what's going on. And objective is really driven by what the chief complaint is. So if they're coming in for a cold and sniffles, you're kind of just going to stick that HENT, check the vital signs, trying to get them to get their temperature, find out what their temperature is, pulse. If you're lucky enough to be with that person and you have the tools, the pulse oxidation is a huge one. You can actually observe their respiratory rate and whether or not they're having difficulty breathing or struggling to breathe, like because of maybe like a sinus infection or something along those lines. And that's just by watching them. Like if they're taking those big exasperated breaths, like, just watch and listen, you'll hear a lot of that stuff. And then as you're talking to them and they're just breathing normally, you can kind of try to be sneaky, set your watch like a timer or something, and then count their breaths for 15, 20 seconds, and then times it by 4, 3, or whatever it is to equal a minute. And then you kind of have a general idea of what their respirations per minute is. Those are some simple tricks that you can use to kind of get some of those vital signs that you won't be able to get because you're not going to be in person with that patient. And then obviously make sure you write it all down and just be as simple as you can be while still conveying all the information that you need to convey to that provider or to in their record. All right, so objective continued. That's just like I said, the physical exam portion. You want to make sure that you evaluate everything that they're complaining about. If they're saying I'm in for knee pain, you don't necessarily need to test them for a flu, right? It's not going to be pertinent to the chief complaint. So like I said, that chief complaint drives the objective portion.
So see, I just want to make sure, are we still on the slide that has organization or on
Yes.
you? Okay, perfect. Just wanted to make sure.
Yeah, so the slide is more just a guide for me so I can talk
Oh,
through everything
perfect.
that I need. Yeah.
Just want to make sure. Thank you.
Yeah, absolutely. So like I said, you just want to make sure you check all the systems associated with that chief complaint. So if it's uh, upper respiratory, check all the entire head, the head, eyes, ears, nose, throat, or HENT or HEENT. Sorry, that's the big one. And then obviously, if it's musculoskeletal, you're examining that joint or bone or whatever it is that is hurting on that patient. So the next one is assessment, and that is your assessment of what is going on with this patient. It's pretty self-explanatory. Usually, if it's a more serious issue, you're going to need some further imaging or studies done, whether it's lab work or whatever. But in the virtual environment, you're just going to have to do your best and form what we call a differential diagnosis. A differential diagnosis is just a list of possible illnesses or impairments that are related to their signs and symptoms and current vital signs and everything else. So you want to ensure that you go off that and you start breaking down that differential diagnosis to eliminate things, whether you're using their past history or their signs and symptoms. Be like, okay, this specific grouping of signs and symptoms doesn't fit this diagnosis, so let's eliminate that one. And you boil it down to as small of a list as you can, and then you kind of just use what makes the most sense. Like if there's two things left on your differential diagnosis, one is an extremely common illness or virus or whatever, and the other one's like super rare, you're going to go with the one that's more common first and kind of develop your treatment plan based around that. And then, like we said, with the documentation, monitor the patient's response to your treatment plan. And then if it's working, great. If it's not working, you're going to have to go back to your differential diagnosis and treat the next thing on there, or the next most likely thing that it could be. And like I said, documentation is everything. So you'll write out your entire plan, make sure it's all everything that you plan to do is included in there in that SOAP note, and then move on to, or I'm sorry, you're documenting the entire assessment and everything that's related to the assessment, and then you move on to your plan. The plan is essentially what you're going to do. What is your treatment plan for that patient? Whether it's going to be antibiotics for 2 weeks or until they run out of the prescription or whatever the case is. And if you're giving them a prescription or medication, that's where you're going to put it, is in the plan. We're prescribing this medication at this dose for this amount of time. Patient needs to take it this many times a day. Everything that would essentially find on that little prescription bottle, you want to put that in your plan as well. And then how you're going to treat the rest of the illness or injury, like if it's an ankle sprain, for example, a good acronym that we use is RICE, and that stands for rest, ice, compression, elevation. That's a super common one, and that's what you're going to put in there. Or instructing patients to follow RICE times a week or 2 weeks or whatever the provider or the doctor says is appropriate. The plan is super easy, but it's always changing. So if, for instance, the plan doesn't work through your response to the treatment plan, it does not work, and then you go back and you reevaluate and change what it is that you're trying to do or treat. So that's the SOAP note in and of itself. And so we're going to get more into some of the other stuff and like kind of the reasoning behind, or the benefits of the SOAP note. And a big one is the improved communication between the patient, the nurse or the medic or whoever's doing the initial screening, and the doctor or physician. So the big things about it is it gives you a clear and concise form of communication, which is going to give you a more efficient process throughout that entire screening session. You're going to prevent accidents. So when you have miscommunication, it usually tends to lead to mistakes. And you don't want to have mistakes, obviously, in healthcare, because that leads to further injury or further harm to the patient. We want to do what's best for those patients. So eliminating miscommunication as much as possible is always beneficial. And then correct diagnosis and treatment. So a diagnosis is very difficult. Uh, Regardless of who you are, it's going to be hard. And especially in the virtual setting where you're going to have less access to the patient itself. So labs and imaging and that kind of stuff is going to be a little bit tougher to come by. So you want to make sure that you're doing the best that you can to get as much information as you can so you can make that correct diagnosis. And that's where the documentation comes in, because you can always refer back to everything that you've talked to that patient about, as long as it's included in those SOAP notes. And that's going to help you form a better treatment plan. And honestly, the last one is huge, and it kind of ties into next month's workshop, and that's reduce stress. So when you have good, clear documentation and communication between all lines of healthcare or all echelons of healthcare, you're going to reduce the stress on everybody, because you're not going to be worried about, oh, did I forget something, or did I miss a step, or did I miss something that I shouldn't have missed. If you can look back and like, oh, I forgot to check their temperature. I forgot to check whatever it is. Obviously, you're not going to forget temperature most likely, but as an example. So that way you can go back and check your notes and make sure that you're giving the best treatment possible. So hopefully it reduces that stress level on all parties involved. Also, as a patient, if you see that whoever's treating you is taking copious amount of notes, it kind of relieves your stress. You're like, okay, cool. They're doing everything they can to take care of me. So then the next thing is quality control. So this is big. This ties into a lot of different avenues that aren't necessarily directly related to patient care, but it's related to the healthcare industry. So it's used for review. A lot of times, doctors, physicians, nurses, whatever, they're going to go back and check your previous notes to ensure that your treatment plans and everything are consistent and up to par. Like you're not missing steps, you're not failing to document things. And then the money comes into play a little bit too, because the insurance people are going to be checked to make sure that you're coding correctly so that they can recoup the amount of money that they want to recoup. And then the next is ensure quality of care, like I said. So you're making sure that your care that you're giving to people are going to be is going to be quality care throughout the entire process, and not like, oh, hey, this nurse isn't doing this where this one is. You kind of compare and contrast the different treatment plans between the providers, and you can see, oh, hey, I can improve my patient care if I do this, just like my peer is doing. So it helps with just improving the care and the quality overall. And then obviously, if you do find mistakes when you're going back and doing that review process, you can learn from those mistakes, which is going to improve you as a provider and a caregiver, so that you don't make those mistakes in the future, and you can teach other people, hey, this is what I learned when I made this mistake. So now you don't have to make the same mistake. And again, it's just going to improve the consistency and make sure that everybody's getting the same level of care throughout your entire organization. With that, do you guys have any questions for me just about the SOAP note portion that we've gone over so far? Let me stop sharing my screen real quick. There we go.
So I'm curious to know, like, what's the protocol if you catch a mistake in a SOAP note, or if you realize that there's been a lack of communication or a barrier to communication?
That's a great question. So when you do catch those mistakes, obviously you want to learn from them. And so sometimes, depending on the level of that mistake, it's not like every mistake is treated equally. So if you forgot to, just document one small thing that doesn't actually affect the overall care of that patient, it's just something that you forgot to document, that's not a huge mistake that you're going to get hassled or hammered for. But it is something to learn from, and so there will be that whole retraining process, and typically that's what it is for all mistakes. Like, hey, you missed this, so we're going to retrain you on just that basic step, and then so you can implement it in the future. If it's something huge that could potentially be like a malpractice thing, then that's a whole other ball game that I don't really want to get into, because there's a lot to it. But great question. Usually, to answer it simply, it's going to be retrain, and then it's going to be in like the lessons learned category. What other questions do we have? Okay. If you don't want to come up and say it on the video, you can definitely type it in the chat window, and I can answer it there as well. All right. I don't think there's going to be any more, but the next thing that I wanted to talk to you about briefly was going to be our scholarship opportunity it's for a number of different programs. It could be medical school, dental school, veterinary school, CRNA, and clinical psychology as well. It's a pretty sweet scholarship. It pays for 100% of your tuition for any of those programs, as well as giving you $2,466 a month just to go to school, essentially. And then once you're done we'll stay with medical school because it's the most common one. Once you're done with medical school, you go on to your residency, and then you don't owe the Army anything until after you complete your residency. And once you're completely board certified and everything, you serve as an active duty physician within your specialty for the number of years that you use the scholarship for. So if you do all 4 years of medical school, you'll owe 4 years of active duty service once you complete your residency. It's an amazing, amazing opportunity and program, and I encourage everybody that's interested to reach out and ask questions, because, like I said, it's pretty awesome. You get paid to go to school while they're paying for your school, so it's hard to beat. But again, I'm going to be here for the rest of the time of the workshop. If anybody has any other questions about anything, whether it's the Army, whether it's SOAP notes or the scholarship, doesn't matter. Feel free to ask.
That scholarship is the HPSP, right?
Correct. It stands for Health Professions Scholarship Program. And yeah, HPSB for short, because the Army loves their acronyms. But yeah, it's fantastic. We just had a question in the chat box, and he says, so we don't pay anything back, we just serve. Yes, that's absolutely correct. You don't have to pay any of the money back. Well, if you fail out of medical school, then you do have to pay it back, but that you shouldn't. I don't think anyone's going to fail out of medical school that actually makes it into medical school if they were really truly dedicated. And the Army will do everything they can to give you the best possible chance to pass everything. But yeah, you just serve the amount of years that you use the scholarship for, and then if you enjoy the Army, you can stay in. If you don't want to be in the Army after that, you can definitely get out and try your luck on the civilian side. And after serving in the Army, you have a lot of leadership experience that a lot of your peers won't have, which will make you more competitive on the civilian market anyways. So it's essentially a guaranteed job for after residency with competitive pay and leadership experience. Okay, that's a great question. As a medical provider, what experiences or things have I experienced as an Army medical provider that civilian doctors won't experience? So first, I'm not a doctor. I appreciate the promotion, but no, I'm a medic, which is more similar to like a paramedic or an EMT on the civilian side. But to answer your question, the majority of the things that we experience that the civilian side won't see are going to be trauma related or combat related. However, the civilian side sees a lot of that stuff too, depending on where you're working. So if you're like an ER doctor, you're going to see just the same amount of stuff that we see in combat. It's just you'll see it more often. When you're just serving regularly, like as a medic, unless you're going down like on a deployment, most of the stuff you're going to see is musculoskeletal injuries and just the sniffles, coughs, colds, flus, that kind of stuff. So it's really pretty similar to what you see on the civilian side. And then, will you still be paid a competitive wage after serving the 4 years? So if you're serving 4 years and you continue service, it's still going to be competitive. Where it starts to get uncompetitive with the civilian side is when you start to have multiple specialties. So if you're do another fellowship or you do another specialty or residency or whatever the case is, and you have multiple things, then the Army's only going to pay for one of those, meaning your salary is going to be based on whichever one you're currently serving in. And so the civilian side, you could potentially be working in both those specialties and getting paid for both of them, whereas the Army's only going to pay you for the one. That's where it starts to get less competitive. But they're going to do their best to try and compete with that civilian market because we want to keep our doctors as long as we can. And then coming out of medical school in your residency, you will be a captain in the Army, which is the third rank on the officer side. It's pretty good starting pay. You'll be looking at 6 figures coming right out of residency, which is pretty good. Okay, so that's actually a fantastic question. When you were deployed, did you have access to medical equipment or did you have to improvise? So yes, we do have access to medical equipment. However, a lot of times in that deployed environment, we end up going through our medical equipment faster than we can be resupplied. So we do have to improvise quite a bit. And I would say, to go back to the previous question, the difference between Army and civilian medicine, in the deployed environment, yeah, there's a lot of improvisation, especially as a medic. They call us the cowboys of medicine. At least the doctors do. They're not our biggest fans when they see a patient come into the aid station or hospital, because we duct tape people back together and do all kinds of just insane things to sustain that life and keep them alive long enough to get to the doctor who's going to fix them. Um, so yeah, we have a lot of improvisation and that, yeah, on a lot of different levels. I can tell you more stories, but some of them can get pretty gruesome. So I'd rather do that more on like a one-on-one basis if you really want to know. So when we serve the Army after receiving this, multiple comments coming in. When we serve the Army after receiving the scholarship, can we stay in our home state or will be deployed anywhere they choose? So when you get through with your residency, first of all, you might not end up staying in your home state just for your residency. That just kind of depends on where you match to. But secondly, after your residency, you go off to what we call needs of the Army. So how that works is based on your performance at residency and just what you have on your wish list. And you can pick, out of the available Army duty locations, which there's a bunch of them all over the place. Army's gonna say, hey, we have your specialty open for your rank at these places, and you kind of have to choose one of the ones that they give you that's available. And so that's kind of where it goes. You have a little bit of control over it, but you are most likely going to leave Florida because there's no real places or positions here in Florida for physicians in the active duty side. And what's the age cutoff for the scholarship? And once you graduate, will you attend OCS? Fantastic question. The age cutoff is 42. So I think pretty much everybody on here is going to qualify. And then you don't actually attend OCS. So while you're in medical school, if you're accepted for the scholarship, typically between your first and second year, you're going to do a course called the Direct Commissions course. And what that is that's like an introductory course to the Army in general, how to wear a uniform, how to march in a line, and all that fun stuff. Typically those things are associated with like basic training, but you don't go through your normal basic training where a dude in a funny hat's yelling at you and making you do push-ups. They'll still make you do some exercise, but it's not going to be as aggressive, I guess. It's more of a professional course. And then between your second and third year, typically you do what we call the Basic Officers Leaders course. And that's just your introduction to Army leadership, because as an Army officer, you are going to be a leader or considered a leader from day one. And so they want you to have that knowledge of how they want you to lead. And that's really just the basics of it. But yeah, 42, and there's a couple training courses, but no OCS. Are there a lot of opportunities for medical professionals in psychology? There are. Well, I don't know if I want to say a lot. There's a few, and it's a growing field in the Army, because I think the Army's starting to realize how important it is. And so clinical psychology, especially, we have an HPSB program for that one, but it's only a 2-year and a 1-year scholarship. So you kind of have to wait until you're towards the second half of that program. And then from there, you can also apply to a couple other programs. The one's called the CPIP, and that's an internship program. And then we have a residency program for clinical psychology as well. We actually just had somebody from Nova's clinical psychology school move on to the residency program, and she's doing fantastic up in Madigan Army Health Center, or Madigan Army Treatment. Yeah. Anyways, up in Washington State, it's fantastic. And then serving 4 years, what service would look like for someone interested in pediatrics? So pediatrics is like the one specialty that we don't really have a lot of positions for. There's a couple out there, so it is possible, but the chances are pretty low for pediatrics, just because people don't really want to leave it. They like it a lot. But it doesn't hurt to try. But service is going to look the same. If you do get that specialty, it's going to look very similar to what you would be doing on the civilian side. And the same with most of the specialties. Whatever they would do on the civilian side, you're going to be doing for the Army. You're just going to be doing it in a nice fancy uniform. And you'll have to do exercise every now and then, and learn how to shoot a weapon. Those are the big differences. But when it comes to like just the actual job itself, you're still going to be doing whatever it is the Army hired you to do or trained you to do for that specialty. And then, do you have to serve right after residency, or can we wait? Nope. Yeah, so you do have to serve pretty much immediately after residency. You graduate, and then the Army's going to cut you orders, and you'll have like a month or two to get your affairs in order, but to move. And the Army will pay for your move. They'll pay to move your immediate family. So if you're married and have kids, any of that stuff, they're going to move all of them with you. If you have parents that are financially dependent on you, the Army will move them as well. Okay, so, oops, sorry. Don't know if this is a dumb question. No such thing as a dumb question. But are medical providers safe from harm's way while in wartime, while serving as a medical provider? So as a doctor, I'm going to break it down to two things. As a medic, which we're still, I guess you can call medical provider, but as a medic, you're not necessarily safe, but that's my side of the house. As a physician, which is more what you would be if you participated in the scholarship, you're going to be exponentially safer than the medics. The Army puts a lot of money into their physicians, and they want to have the best or most return on that investment as they can. And so they don't want to put them anywhere near the danger zone if they can avoid it. Having said that, there is the opportunity to get closer to those front lines if that's something you're interested in. We have what we call Forward Resuscitative Surgical Team, or FRST, and they have a very, very small tent. It's like a 1-bed surgical room, OR, that is transportable. We can move it and set it up within like 2 hours. And then it's a fully operational, you can have sanitation and everything done, ready to go to, perform an operation in 2 hours. It's pretty incredible. And those ones are going to be a little bit closer. But for the most part, if you're a medical provider, you're going to be in a hospital behind a bunch of barriers, and you're going to have a bunch of dudes. We call them grunts. They're infantry guys. They're going to be a bunch of those guys in between you and the front lines, so you'll be safe. And then, is there anything for PA school? So PA school is a little bit different. The Army loves PAs. We do. We use them a lot. They are typically the first provider that you're going to see in the echelon of care outside of the medic. So the medic will take it to the PA will continue stabilization and then push it on to the larger hospitals. However, we don't have any scholarship programs for PAs. And the reason for that is that the Army has its own PA school that is accredited through Baylor University. So they aren't going to give scholarships for PAs because they'd rather you come in and then go to the PA school. Unfortunately, I wish they did have something that we could offer PAs. That'd be fantastic. Or a PA school. People that are interested in PA school, that'd be great, but they don't. We do take PAs in what we call direct commission. So if you finish PA school and you still want to join, you can absolutely apply to join that way. As a medical provider, when deployed, do you only help harmed Americans or all people, like the enemy? So, as a medical provider, our job is to care for everybody. It doesn't matter. We triage, and whoever is in the most dire need of care, that's who we go to first. That's just kind of the rule of the game. Like, you don't get into medicine just to care for the people you like, because if that was the case, a lot of people would probably be suffering. And so we do everything we can for everybody that we can. I hope that answers your question. And then do you simply apply? Oh, that's a direct question. Or, well, that's actually a good one for everybody to know. The question was, do we simply apply for the scholarship on the Go Army website? You don't actually. You apply for the scholarship through a healthcare recruiter like myself or one of my colleagues. And you can call us at any time and we will, well, preferably not in the middle of the night, but we'll call you back in the morning. Definitely. You call or text or anything, and we will definitely transition you into the scholarship program, help you through that entire application process, tell you where to sign on your forms or whatever, and tell you what documents that we need from you. Like, we'll do as much of the work for you as we can. And if you're willing to work for us, we can process it pretty quickly. Are there spots for people interested in gynecology? Absolutely. We have a ton of gynecologists. And if that's something you're interested in, the scholarship is probably a great way to go. And well, any of the specialties really. So if you have like a set specialty in mind that you really, really want, the Army scholarship is awesome. And I'll tell you why. So the people that receive the HPSP, um, when they apply to an Army residency program, they're put at the top of the list when it comes time for selection for those Army residency programs. They have priority, and so they end up having a better chance of getting the specialty that they wanted. I think last year, 85% of the HPSP recipients that applied to an Army residency matched with their number one residency choice, and so a lot of them got exactly what they wanted. And then I think it was a 97% overall match rate. So a very, very small fraction of the people didn't match. And so that's unfortunate, but most people do. And most people get the specialty that they want. All right. So if I were to go to medical school earlier and later on decide to go to the Army, would the ranking of captain be the same? Yes and no. So if you that it will be a minimum of captain. Let me put it that way. So if you come in as a doctor, regardless of the amount of experience you have, at the very minimum, you will be a captain. Now, if you've been working in your specialty for a while, a few years, you could potentially come in as a major. Lieutenant colonel is possible, but it's just very difficult to get. The difference is when coming in as a major, the authority for that rank is our chain of command, like the recruiting chain of command. But if you get to that lieutenant colonel, which is the next one up, that goes all the way to Congress. And so it takes a very long time. And it's pretty unlikely that they're just going to be like, yep, you can do it. So, but yeah, at a minimum, you'll be a captain. Is there opportunities for pre-optometrists, primary eye care doctors as well? Yes. So I forgot to mention that when I was listing off all the schools, because there's so many that I can't remember. Optometry school is one of the ones that do get offered the scholarship. However, in order to apply for the optometry scholarship, you have to be in your first year of optometry school, because we only have a 3-year, we have a 3-year, a 2-year, and a 1-year. We don't have a 4-year optometry scholarship. So once you're in that first year, go ahead and start applying for the scholarship. It's pretty competitive though. That's one of the more competitive ones. But don't lose heart or don't lose motivation, because if you miss the 3-year scholarship, you can apply for the 2-year. If you miss the 2-year, you can apply for the 1-year. You can keep going until you're done with school, essentially. And then how many are accepted each cycle? So for us, the scholarships are based, or how many scholarships we get are based on our fiscal year, which starts in October. And so every October, they reset the amount of scholarships that they're offering. This year, there was 290 scholarships available. They're filling up pretty quick. They should be full, and we should run out of scholarships probably May or June timeframe. So if you've already started that application process to medical school and you really want to apply for the scholarship, you got to do it sooner rather than later. So the Army program counts as our residency, and should we apply before being accepted to medical school or after? So apply for the scholarship while you're applying for medical school. Once you start that application process for medical school and you have your MCATs and all that stuff, that's when you want to start applying to the scholarship, and that's going to give you the best chance. And then we haven't done like an actual study to find out how true it is, but we have noticed a trend that those that are accepted for the scholarship and they mention that during their medical school interviews, they have a pretty good chance of that school going, yep, you're good to go. For example, I had one applicant, she was accepted for the scholarship, and she hadn't been accepted to medical school yet, and she had a few interviews left, and she had already done like 5 interviews and hadn't gotten a letter of acceptance. And then every interview she did after she was accepted for the scholarship, she got a letter of acceptance from. Is it because she mentioned it? I don't know, but it might have helped sway things in her direction. As far as the Army program counts as our residency, I'm not entirely sure what you mean by that, but I will say that the Army has residency programs, and you go to one of the Army hospitals, and that's where you do your training, and it's the same as any civilian residency. And you still take the same boards and everything that you would through a civilian residency program. Whew. You guys had a lot of great questions. Some of them I haven't actually had before, so I appreciate it. It was fun. Are there any other questions out there?
Sergeant Allen, thank you so much for taking the time today. I agree, definitely some great questions and some great information. Thank you for leading it on the SOAP notes and providing more information on the scholarship, and more than anything, thank you for this collaboration and providing this opportunity to our students to develop these skills, immerse themselves in this knowledge. But we appreciate your time and everything you do for our students.
Oh, no, I appreciate you guys having me on. It's great. For me, my favorite thing about the recruiting side is just getting to talk to people, and I just like talking, I guess, in general. But yeah, so it's always fun. I'm gonna go ahead and drop my email in the little chat box for. Oh, that was a direct message. I meant that to go to everybody. Sorry. So I'll drop it in the chat box. So if you do have any other questions, or if you're interested in the scholarship and you just want more information, feel free to email me, and I will answer whatever questions you have.
Awesome. Thank you so much, Sergeant Allen. And again, students, this recording is going to be available to you. We're going to try to get it posted by the end of today, and it's going to be on our YouTube channel as well.
Awesome.
Thank you again, and we'll see you at the next workshop. And students, keep an eye out. We'll be having a lot of workshops this semester to support you and immerse yourself in telemedicine.
All right.
Thank you.